Well, hi, everybody. Thanks for being with us tonight. I'm going to pretty quickly get over to our presentation, but real quickly, just want to say thank you for spending your evening with us. It's always nice to have people have some interest in what's going on, and especially as a NP in the OR, it's a unique role, and there's always something new going on. And as you're going through the decision of either going into a first assist role or the different roles that are out there, I want to do a fun little presentation tonight more on the idea of what CV surgery OR looks like. Previously, I've given some webinars talking about just what that general role is in the OR, and this is a little bit more specific to what my daily life looks like. So hopefully it's something you find kind of fun, and we'll go from there. Feel free to ask any questions as we're going. So let me pull this up for you and we'll get cooking. So the title of this is Cardiac Surgery 15 to Life. And when you work in CV surgery, I think the big disclaimer that people say is, oh, I'll have surgery once, but then I can go do whatever I want because, hey, I got new pipes. What's the big deal, right? And I feel inclined to say, we're still using your own arteries and veins to make all the bypasses. It's not like we're getting brand new, 0 years old equipment here. So you have to recognize that we're still working with some outdated supplies here. So I think people think about cardiac surgery as the fix-all, but I try to encourage people to say, we're still dealing with the same stuff going through the pipes. We may have fixed the pipes, but you have to change what's going through the pipes. Otherwise, you're back to where you started. So 15 to life, the title is basically talking about 15 years to the rest of your life is what a bypass should last you if all goes well with it. So when you talk to your patients and they say, how long should this work? Well, hopefully the rest of your life, but it doesn't always last depending on how you take care of yourself. So we'll go through some of this. Hopefully this is fun for you and enjoyable, just something new. So there'll probably be some quirks. This is the first time presenting this, and I'm excited to bring it to you. So my name is Dr. John Russell. I'm a nurse practitioner in cardiac surgery. I work with NIFA as the APRN RNFA program director for the college division. I work to help kind of develop some of the relationships with schools and helping APRNs get kind of plugged in. And I work in CV surgery part-time now, and I'm very busy with a company I own called Skills on Point. We do a lot of medical education and CE content around the country through a lot of schools for people just making that transition from RN to NP and then being prepared for the procedural and privileging things you need. I also have a 501c3 that's based off the same concept there, where we can help people doing medical missions and service missions to use their skill set and help train people for free and resource them. So kind of a fun thing we're doing. So a little bit about me, and I don't say this because I want to see this on the screen about what I've been through, but I want you to pay attention to this as I go through this. Nothing about this has anything to do with the operating room. So I started in the Air Force and was doing that through 2007. Halfway through there, I became a paramedic, kind of fell in love with medicine. I married a nurse, and she said, hey, you should become a nurse. You'd love it. And she was right. So in 2008, I became an ICU nurse. And I went on to do what was a little bit less of a medical surgical ICU to being more of a catch-all ICU that included CV surgery. And that's where I kind of fell in love with CV surgery. In 2014, I started with a family nurse practitioner and had a master's, went on thereafter to get my NIFA training after starting in the OR in 2014. And thought that was a pretty good jump start to my skill set to be successful. I was continuing right after that to get a DNP in 2016. And right after that, wanted to do something kind of fun with my skill set that I learned with my doctorate to implement practice change, and looked at myself and said, hey, I had a hard time finding some of those skills to get me up to speed, to get the skills to be successful as a FNP that didn't really have the specific training to be in CV surgery. And after bouncing over conference to conference and around the country, trying to find all the right skills, I figured, why don't we just centralize that? So that's what Skills on Point was designed to be. It was a way to kind of make a clearinghouse for the skills to get you it without having to pay an arm and a leg for things you didn't really need. And then we started our nonprofit and kind of kept on working alongside a NIFA here, and a more expanded role in 2019 as a program director. And then this last year, I went through a postmaster's acute care cert so that I could be truly board certified in my specialty, having not really worked as a family practice NP and really worked in an acute care setting. I went to get my acute care just to be board certified in my specialty. So I'm dual boarded, and I keep both of them up. But that said, it's, the world is always changing with certification. So I wanted to make sure I was ahead of that. So what are we going to talk about tonight? Well, we'll follow me through an entire care continuum of a CV surgery patient, kind of what they go through, and a common way that you may see patients at different spots kind of plug into the circuit of needing bypass or maybe getting stents instead. Some things that maybe you didn't know about. Common surgeries that CV Surgery First Assists perform. I'll just kind of go through some of that and see if that sounds interesting to you, and maybe this is something that maybe NIFA can help you get some training on. We'll discuss some of the training required for those unique specialties. CV is very procedure specific. There's lots of things you do, but it's very repetitious. Just like anything, there's differences, but there's a small bouquet of skills that you'll use a lot. And then specifically, I want to talk about how NIFA's APRN RNFA curriculum will uniquely prepare you for this role and how I feel that prepared me. So let's talk about this guy here. He's a very typical patient that we would see in my practice. This could be someone that comes in through primary care or comes in through the emergency room with chest pain, however you want to look at it. Let's say a 62-year-old male has some stable angina, some chest pain, short of breath, fatigue, your typical cardiac seeming patient. So if he goes through primary care, maybe they get a stress test and work him up. Maybe they do an EKG or find some enzymes, send him on to urgent care, send him on to the ED. However he gets to the hospital, he gets to the hospital. At that point, they'll do a little bit of workup to say, what is it that's going on? And they find that sure enough, you do have some coronary disease via a coronary angiogram. And depending on how bad the angio is, kind of determines, are we going to do stenting or are we going to do bypass, and kind of what are the options? Sometimes the patient can say, we got 50-50 shot, your call, which one do you want to do? I would say more times than not, people will choose to do stenting because really, who wants to have a big incision down their chest if they could just have a little poke in the wrist or the groin? I mean, I would too, right? But there's some times where we know this is not as ideal. So that's really the big question comes in of what are the options? And then usually it ends up being stents versus CABG, or if it's something other than a anatomical issue for the coronaries, it could be a valve issue or all kinds of other fun stuff. We'll talk about that. So we'll do a pretty thorough workup at this point and decide, hey, is this person even appropriate for surgery? All things considered equal, maybe it's a 50-50 shot, but they don't have any vein, so we don't have a real good way of doing bypass because they've had their leg vein stripped. Or maybe they've had previous surgeries and they've had radiation to their chest or something that makes it like a real, I don't think this is a great idea. All things considered equal, nothing's really going to be a better benefit for you if we just can do one bypass or have a bunch of complications. Let's just get you stented and move on. But that said, in a lot of cases, we go, well, yes, this is a slam dunk. You've got multivessel disease. Let's do this. So we'll go through a pretty considerable workup. We'll look at everything pretty much head to toe. Pretty much every body system will be evaluated and put into a risk calculator so we can decide, hey, what's your actual risk unique to the person, not just in general. What's your risk of strokes? What's your risk of having a sternal incision dehiscence? What's the risk of, prolonged intubation or return to the OR or mortality or morbidity or mortality, kidney disease, kidney dysfunction, all that kind of stuff. So pretty accurate databases we can use that have pretty close to 1 million plus people in them. So it's pretty easy for us to say, statistically, I can tell you where you're going to fall, but statistics are just a guess. So my job in CV surgery as a nurse practitioner is both to be in the OR, but a lot of it is I have to be the gauntlet. If they don't go through me as the gauntlet, then they go to the OR. And if I do a good job, there's some people that I don't take to the OR because my job is to be the surgeon's ears and eyes when he's doing cases. And I can stop people that are inappropriate from even making it to our front lines. So I have a pretty cool job. I enjoy it. I have a good relationship with a lot of different specialties in the hospital, but I will say that, it's a complex position in CV surgery where a lot of people will look to you and say, what do you think about this? And it's like, well, I'm not the surgeon. It's really kind of a big deal for me to say it's this or it's that. But the longer you develop that relationship in a facility, they start trusting you a little bit more. And you begin to be kind of the go-between for a lot of those decisions. So it's a very fun role. There's surgery, there's rounding, there's discharges, there's admissions, there's consults, there's all that kind of stuff, but it keeps it kind of lively and interesting for me. So we'll go through the hospitalization, they go to the actual surgery day through the actual discharge. And then at discharge, we're still managing them in the outpatient setting for a period of time for the next couple of months until they're really ready to sign off, be driving again and lifting and make sure their breastbone's healed and all of that. So that's a typical timeline. It really starts from day one up to the day of surgery is kind of a variable amount of days. It could be a day or two, it could be a week or a month. But once they commit to surgery, it's usually about a week in the hospital. at most, sometimes 4 days, 5 days, but sometimes it's a week-ish or a little bit more depending on their complications. And then usually we'll see them for about up to 2 months after surgery until they're really ready to sign up. So we're making a commitment to this person to really be involved with them. Some people like that about this. Some people don't. Some people say, I'd rather, fix it and forget it and move on. But that said, that's kind of the fun part about this is we have some long-term relationships in it. So one of those decisions that we make is, can we stent it or can we do bypass, or what are we really making the decision on here? So this is really what has reduced surgical volumes considerably over the last decade, is the advent of the stent and the advancement of the technology so that it's really going to be a great option and have longevity. One of the biggest things that they've come up with in the last couple of years here that has worked pretty well, it's called drug-eluting stents, that they actually put out an anti-rejection medication very slowly, and it slows the endothelial lining growing on the inside of this stent. So it doesn't just really quickly grow in there like a big scar and then plug up again. So the slower it grows on there, the better. But the sideline with that is you have to be on blood thinners. So some people, they're just non-compliant or whatever's going on in their life, that they're not going to take their meds very well. You have to think about that and say, well, maybe this isn't the best option for you, and you shouldn't have that. But really all this would be is the angiogram. They identify a blockage, and basically they throw a balloon inside here, like this picture on the top here shows. They inflate that balloon, and then they'll put a stent in there. And then more or less the stent acts as a little support to push that plaque out of the way. It can certainly grow back there. It can certainly come back pretty quick, in fact, but it just depends on how well the patient takes the right medicines and where the anatomy is. So why not just stent everybody? The reality is not everybody would do well with this. If you think about a tree, sometimes there's problems in the trunk of the tree or in the branches or right where it forks off. It can be a higher risk at those bends or in the trunk of the tree, because if there's a problem, then the whole tree has a problem. So we tend to do stenting kind of in isolated spots out in the branch, hopefully not where it's going to cause other little limbs to die. We try to do it in the open spaces on the limb. Not always, but that's kind of the idea. Bypass, on the other hand, is what you see in this picture, where we're actually making an incision on the chest, and then right down the middle of the incision here, we spread the chest. I'll show you some pictures here in a minute. And then what you see here, this picture is showing a vessel coming down and then plugging into this red vessel here, which is meant to identify the left anterior descending. And then on this side, you see a vessel coming down and plugging into it represents the right coronary artery. And the difference here is where it attaches up to. This one up here is going up to a blood vessel in the left chest called the left internal mammary artery. And that left internal mammary artery is attached at the top as much as we can. Sometimes we have to take it off on the top, but think of it like a pendulum. We just swing it over and plug it into a new spot, but it's still attached at the top. That is the most important bypass we do. And all the rest of them, we use vein. We plug into and make a little hole in the aorta, and then we plug it in and go down to the other areas that need bypasses. So it's a combination of whatever they need, but certainly for an isolated coronary artery bypass grafting, it is usually going to be a combination of the artery for the left side, and then a graft on the right or other branches of the left too. So really benefits of stenting, if you can imagine, the patient comes in, they go out the same day, it's a same day fix. I like this picture. I think it does a pretty good job of showing. Very far left shows that real isolated blockage right there, left to that arrow. This is what you'd expect to see being what we call a slam dunk. I would probably not expect to get a call on this patient. This would get fixed before they even thought about calling CV surgery for a consult and stop the progress. Patient may be having chest pain, maybe having symptoms, maybe having nothing going on, but this blockage is one obvious isolated area where it's kind of like an hourglass. And then after they put that balloon in there and put the stent in there, you can see there's good flow through there. So you wouldn't need to put them through a big surgery when all you had to do is one isolated fix there. And the rest of it looks fairly reasonable. There's some plaque and junk in there too, but certainly it's pretty wide open. So why put someone through a big surgery if you don't really need it? Some people are just kind of frail in general. And if they're having chronic chest pain, even someone that's kind of end of life and they're uncomfortable and they have chronic chest pain, even doing a stent like this is it's a very minimally invasive thing compared to surgery, where you could say, we don't want you to die in the next couple of months having all this pain. This may be something that gives you quality of life. So it can be a palliative thing just as much as a reparative thing. No big incision needed. You can poke through the wrist or the groin into the arteries to do this, depending on the size and where they're at. and how bad your coronary, I'm sorry, your peripheral vascular disease can be. If you have really bad peripheral arterial disease in the groin, sometimes they can't go there. Sometimes it just depends on how many blockages you have. We'll go in there multiple times. We call it staged procedures. If you have really bad kidneys, they'll do just one and get out of there and come back later and do one and get out of there. All that's doing is protecting the kidneys so that you're not putting a lot of dye load on the kidneys. The dye is really bad. Contrast-induced nephropathy is really bad for the kidneys. But that said, contrast-induced nephropathy is less of a stun to the kidneys than going through coronary bypass surgery. So if all things are equal and you're kind of worried about the kidneys, stenting is safer. And again, it's tolerated by people that you're like, there's no way I'm going to get through to even consent to surgery or go through surgery successfully. Stenting is much less aggressive, but it does work very well. Drawbacks of stenting, sometimes you just can't do it because of the location. I think this is a pretty nice picture showing that. You can see this is a big trunk of the tree here on the left side, and this is called the left main coronary artery, and then it branches off. And this is kind of a unique vessel, the way it's organized. I'm sorry, this is actually a left anterior descending. This is the left main up here. This forks off to the circumflex. It's kind of small. Either way, this is a pretty weird vessel here, right at this big vessel going down, and then it narrows down. It's kind of a tiny little whisper going through that diagonal. So point being is, this is something where you say, well, if I put a stent across this, I'm going to knock this off, right? If my stent goes from here to here, I'm not going to have blood flow through there. So it wouldn't make sense. Yes, I could put a stent there, but I would knock off all that good blood flow going through this. And there's techniques where you can try to stick a wire through there and do what's called a kissing stent and kind of fork it. But the problem is, it's really not as ideal. This is a slam dunk bypass. All right, great big vessel here, great big vessel there. No reason why you couldn't do two bypasses there and fix that problem. Kind of got some disease back here, but it's kind of small, so probably not gonna do much about that. And we'd also look at the right side at the same time and see what's going on there. So again, this is one of those things where, right, we call bifurcation lesions. These tend to be a little bit more of a slam dunk for us to say, hey, or if they've already been stented and they already had a failure of a stent, you could say, hey, we've already tried, they didn't tolerate it, or the body kind of rejected that and the medicine didn't really work for them, or they weren't therapeutic on their Plavix or whatnot. So they had issues again. So they want to proceed with surgery. So lots of reasons where we may decide to do that. One other thing too is if you have left main disease way back here, again, at the trunk of the tree, if you have a trunk of the tree problem, and you have a problem when you put a stent in that and the stent fails, the whole tree is done. So that'll basically wipe you out pretty quick. That's the whole left side of your heart goes down. Chronic total occlusion is another thing. They do stenting for chronic total occlusions, where let's say you have a blockage here that's 100% blocked, but there was enough we call collateral flow. Somewhere else kind of fed around it and did a natural bypass from real chronic slow disease progression. And maybe they decide they can drill through that and hopefully it goes in okay. Sometimes it doesn't work. Depends on how aggressive the cardiologist is and how they were trained. But that said, chronic total occlusions tend to be something that you'll see surgery for as well. Or if you have anatomical difficulties where it's kind of really close to the beginning of the vessel here, you call this an ostium of the vessel here, the osteal disease. Or you have old bypasses or things where you say, I just don't have a good ability to go in there. It's already been surgerized, so to speak. So they're probably gonna have to have surgery again just because they needed it the first time because they weren't a stenting candidate the first time. They're still not a stenting candidate. So again, there are some drawbacks of stenting that pull us towards doing surgery. Not everybody can be stented. Otherwise, we probably wouldn't have surgeons, right? Some drawbacks of stenting, the cost. Now I say surgery is really expensive, but stenting adds up real quick. You get nickeled and dimed with stenting. And I know people that have had angiograms and it was a couple $100,000 easy in the hardware plus the time in the hospital. And that could be your bill for an entire surgery. So it's not to say that it's a cheaper option to have stents, but that said, if you have one isolated area, it may be cheaper because it's one quick stent and you're done. Not that we care about that, but that's one of those things that if you're thinking about this as the patient side, if they're like, hey, I'm a cash pay patient, please don't hit me with this crazy bill. But the bad thing here is you have to be able to, recognize that, hey, you need 7 stents probably by the time we're done. You've got all kinds of disease. And if you're not compliant with the things like aspirin, Plavix, to keep your blood thin so that drug-eluting stent can really take its time to slowly grow in, you're going to have a stent failure or premature stent failure or in-stent restenosis. When that happens, you find yourself, unfortunately, in a really bad situation, and the stent's plugged down and they have to go back to the cath lab. They're having a heart attack. So the little placard here, yes, I'm compliant. You know, every patient says, I'll do whatever you say. I don't want to have surgery. And then they go home and they go back to smoking and you say, just kidding, you are not serious. And they don't take they never even picked up their Plavix from the pharmacy. And, you know, we find this stuff out all the time, and it does happen rarely, but it does happen. And the other thing is you have a patient with like a GI bleed and you're like, well, I really can't put them on a bunch of Plavix. Well, then you have to think about fix the gut issue if you can, but you may have to take them for surgery because you can't commit them to a chronic GI bleed issue with the stent. So you'd have to do something other than that. So it's not always an obvious option. It's not always an easy answer, but it is definitely something we have to be very, very thoughtful about how we choose who gets what. Obviously, you want to be judicious about putting your patients at undue risk. So the benefits of CABG, grand scheme here, why would I want to have a CABG if it was me? Well, the reality is it's only going to last as long as your body wants it to, but statistically speaking, that left internal mammary artery, that vessel on the left side of the chest, you have a right and a left internal mammary artery, or left internal thoracic artery, sometimes people call it, but the lima is the most common one used because it happens to be anatomically right by where the left anterior descending sits. So it's a nice, easy, free it up, swing it over and plug it in. And that one is after 10 to 15 years is greater than 90% patency rate. So it's still going to be working. So that is a great blood vessel to use. We always try to use that if we can. And then the other ones are all veins being repurposed. So they're not as good, but they're very good. And they're the person's own veins. There's not like you can really use a graft. It'd be nice if you could, but it doesn't really work like that on the heart. We use a saphenous vein from the leg whenever we can. It tends to be about the right size. It's a long conduit that goes from the groin to the ankle on both sides of the leg. And we could use those as just a branch of the tree, so to speak. It's not the big trunk veins like the femoral vein in the leg. So it doesn't really matter if we take it out. It's just pruning off a branch, so to speak. In fact, it's the most common blood vessel that people will have taken off if they're getting sclerosant for like varicose veins or veins that are just painful on their legs. So it's really of no consequence to get rid of those. But people always ask, is this going to be a problem of what happens where the vein was? And not a big deal. But I will say that the leg we do this on tends to be swollen for a little bit of time. The biggest stigma with this that I have found is that I've moved into this career in the era of endoscopic vein harvesting. And there's a lot of people who have family members that were recipients of bypasses before this. And they were in that era when they did an open harvest on the leg for the vessel, and it was a big incision down the leg. Very commonly, people would say that was the most painful part of it, not the incision in the chest. So with the advent of endoscopic vein harvesting, that's one of those things that really reduces the pain, expedites the recovery, reduces the amount of infections. It's a fantastic thing. And quite honestly, it's the standard of care. So if you're not seeing that, it's something that you can certainly train on. It's something that NIFA can train you on in the middle of that 5-day workshop. It's something that Skills on Point can train you on if you've already gone through NIFA. There's lots of things that we can do to kind of make sure you're up to that skill. I have surgeons that come from around the country that are just learning. They just want to learn a new skill because they've always done it open. And then some of the international surgeons that they're doing things in different countries and they don't have endoscopic gear because it's all single-use throwaway supplies. Everything they have there, they have to do open just because of the cost. So they want to learn new skills and bring new skills with them. And that's one of the things that we always want to make sure we can offer. So that to say, this is pretty much the state of the art is to do this endoscopically. They last longer, they work better, but it does take some skill and time to train. So this saphenous vein grafts, this is kind of my spot in the OR. This is what I'm doing. So also this is going to be a benefit for CABG. These are the patients that can't get a stent due to anatomy like we talked about. And this provides new blood flow. So you imagine you have an old house that has really crummy pipes and you say, well, I'm just going to run a snake and clean out all the like rotor-rooter, all the nasty pipes out and it'll be fine again. Well, maybe, but it's not quite like new. So if you're putting brand new pipes in there and leaving the old pipes alone, for one, you're not disturbing the old pipes and having weird stuff go flying through the pipes, causing peripheral problems or stuff coming back to the heart. In fact, what you're doing is you're adding a brand new pipe from a good source to after where the blockage is. So all you're doing is adding truly a bypass around the blockage. You're not tearing something out, putting a new vessel in. That's what I thought we did before I started this. Like, oh, it's all we're doing. It's just like a little jumper cable. Yep, that's all it is. Pretty simple. He's got to find a good spot to plug it in and a good spot to, on both sides, plug it in at the beginning and plug it in on the actual blood vessel. So pretty cool. So what are the risks of CABG? I always like this picture. The person on the left I see all throughout our hospitals. I feel like she's more popular than she should be, but this is one of those stroke pictures that say, hey, if you identify someone who looks like this and they're having a stroke, it's a very, very low risk of having stroke after surgery. But that said, it can happen. And if it does, it's something you want to obviously identify early. People that have vascular issues, they may have carotid artery disease as well as coronary artery disease or peripheral artery disease. Atherosclerosis is, it's junk in the pipes, right? That's why we're here. That's why we're doing surgery, because it's everywhere. So it's not uncommon to see the aorta may have some atheromatous, like tumbleweed-like plaque sitting in there that could get flicked off in the process of surgery. Or it could be just something that happens at a sheer whim. But that said, the risk of strokes is usually between like 2 to 3%. It's really low. This guy on the right, again, he's smiling. He's loving his dialysis. Obviously, this is somebody who has a fistula, who's used to having dialysis, but you certainly don't want to have the surgery and then be like, well, surgery went well, but now you're on dialysis because we knocked off your kidneys. Obviously, that's not something we'd choose to do. So we have to be very thoughtful about the risks of all the different body systems. So the biggest stroke risk, you can have a heart attack because of surgery. I know it seems kind of odd. We're going to surgery to fix your heart, but that could actually cause a heart attack in the process. We're playing with your pipes. Things can get weird. GI disturbances, we could cause one of those things to flick off and cause a blockage in the gut. Kidneys could have problems. Blood disorders. Heparin-induced thrombocytopenia can happen where you have a heparin allergy. Infection in the sternum, usually, if at all. And then obviously death if it's real high risk. So, it's not a benign surgery. When there's a complication or a side effect with the big surgery, it's a big complication or a big side effect. So we don't take it lightly. So here's some of the procedures for CV surgery first assistants. And you may have other procedures you do other than this. You could do some more advanced things depending on where you work, but these are the most common things that you would be doing as a CV surgery first assistant. Coronary bypass grafting obviously is going to be bread and butter. That's a very, very common thing to do. Probably about 50 or 60% of your cases will include this. Aortic valve replacements, very common. Mitral valve replacement or repair, probably not as common as aortic. Maze procedure is a procedure that is done to basically reduce the AFib that people may have if it's not been too chronic. Plication, I'll show you some pictures of all this stuff too. Plication is shortening an aneurysmal heart. Left appendage ligation, left atrial appendage ligation, a very common procedure to reduce the source of most embolic strokes from AFib. Sometimes you'll do thoracic cases too. I do probably about 10% of my days are doing lobectomies or wedge resections, more lobectomies than wedges. But again, a lobectomy is taking the whole lobe. A wedge resection is taking just a little slice out of it. Empyemas or pleural decortication is a big fancy way of saying you've got a bunch of pus around your chest, inside the chest wall, outside of the lung, and we'll basically go in there and clean it up with a thoracoscope if we can, and just make it as small of an incision. Check all the fluid and see what the bacteria is growing. And sometimes it doesn't grow anything, but usually there's some kind of lung infection that kind of festered. And we have to strip the pleura off because it gets all thick and rinded and yucky, and then the lung can't expand. So those are really yucky, stinky cases. Sometimes the aortic root itself, where it plugs into the heart, will be dilated, and we'll have to replace that. Or aneurysms or dissections. These are the things that happen at 3 a.m. when you're like, I want to be asleep, but then the pages go off and you're like, oh boy, I got to get there right now. It's usually because of the dissection. And then rarely, but once in a blue moon, we do a sternal wound repair or wire removals just because there's something that came apart or that needs to be repaired. Plastics does a lot of repairs if you have wounds that fall apart, but some surgeons do this themselves. So this is a picture of a CABG, and I like this picture because, again, on the left, this shows a little better picture of the left subclavian artery going off to the left arm. And this piece right here, I talked about before, but this is the left internal mammary artery. The chest wall, again, kind of goes out to, in front of the heart, and it's basically already in that perfect spot. We'll just kind of free it up and swing it down. This is called a pedicle graft. This has some fat and veins around this artery to kind of keep it as the natural packet of supply to and from it that you normally would have. And this will get sewn in down to somewhere on the left anterior descending if it's possible. It's the best place to put it. And then the vein grafts will go to the other blockages as you see fit. CABG times 3 would typically have the left internal mammary artery plus 2 vein grafts. CABG times 5 would have that 1 artery plus 4 vein grafts. So when you're thinking about taking some vein out of the leg, you'll be thinking about how many pieces you need. It's usually the total number of bypasses minus 1, because that 1 will be from the artery in the chest. So it kind of just depends on the size of the heart too. A big heart, you'll need more vein. A smaller heart, you won't have to take as much vein out. But this is a picture of an actual case that I was in, and this was really a cool case. The retractor is in the chest. It's been kind of pulled sideways so that you can see and the heart is sitting there. There's a gauze being pulled back so you can see. This weird little thing here sticking out is actually an aneurysmal right coronary artery, which is a very odd thing to see, but it's kind of cool. So I took a picture of it. By the way, this picture is just showing some of the cool anatomy that that we would normally see looking down there. The heart's going to be beating while we're doing the surgery until we get them on bypass pump. So with that, you're going to obviously see a lot of really cool anatomy every single time. Everyone's heart looks a little different. You'll see more fat or less fat or different structures. And your job as the assistant in this case is to help the surgeon expose everything and hold opposite them and do a good job of giving exposure for any bleeding or anything needs to be retracted. It's a very, very fun job. So while the surgeon is starting up at the very top, I may be doing endoscopic vein harvesting down the leg. And this is a procedure done with this camera-guided tube that will make a small incision that, if you look at this picture at the top here, this big long incision down the leg that's basically right above where the saphenous is located. If you could make a little porthole instead and make a little poke at the top or poke at the bottom, obviously that's going to be way better for your patient. So we make that little incision, and it's in a good spot right next to the knee, so you can take this camera and go up the leg, and then you can flip around and go down the leg. And this camera is the most common system, the McKay system. McKay and Terumo are the two most common systems used. McKay is probably the most preeminent one you'll see, but certainly every hospital has their own version of what they like to use. And this is a picture of someone actually doing this skill. One hand usually holds at the site, and then you basically run this camera up, and you can watch on the monitor and see kind of like a video game. You're just walking down this vessel. Down here in the far right, you can see this is actually a picture of the saphenous vein. And this is someone who has a nice round tunnel. You can see there's good pneumo in there, and it's pushing all that tissue away. So you can see very, very well. And this little C is something you use to walk down the vessel and protect it. This little piece right there, that's actually a branch that we'd have to cauterize off so that we could get this all freed up like a piece of spaghetti before we take it out. So very, very unique skill that happens. This is more or less a surgery that I would perform while the surgeon is starting the surgery to make the incision in the chest. And this may take 10 minutes, 20 minutes, an hour, kind of depends on how much I got to take and how good it is or bad it is. But the whole point of this is you want to take your time and do a good job so that what comes out you can actually use. It does no good to take it out and have a bunch of holes in it. So this takes about 50 to 100 cases of doing this to really feel comfortable with it. It's not an overnight skill, but it's something that once you have this skill, this can certainly sign you a lot of contracts and make you some great money as a first assistant, because this is a skill that's in very high demand. This is kind of cool shot of an aortic valve replacement. If you ever wondered what it's like to do the aortic valve replacement, it's more or less on the outside of the heart. Again, the heart has the blood eject out of the heart through the aorta, and that separation between the heart and the aorta has a valve. And this is a aortic valve. This is the leaflets cut out of it. This is pretty yucky. Actually, I take that back. That's a mitral valve. But this is an aortic valve. You can see there's a bunch of sclerosed, sticky, gross, calcific tissue here. This is a tricuspid valve. You can see how it's got like 3 leaflets there. This one's all fused together with all this garbage. And this one, it's hard to say exactly, but it's not really opening much. People that have aortic valve disease, they just feel crummy all the time. They just can't breathe. They feel winded. They lay down. They feel like they're panting really fast. It's just really uncomfortable. So you take this out. It's kind of like restrictor plate racing. Your heart works well until you try to eject the exhaust and the blood in this case, but you have a restrictor plate there to keep you from having too much power on a shorter track for a car race. Well, the same thing happens here. Your heart works fine, but it can't get out. So not as much gets out to the body. You stand up really fast. You feel like you're going to pass out or whatnot. So this is something we'll just cut this out and set it on a thing like this, and we're good to go. This is actually a pretty cool picture of a mitral valve. This is a piece of a papillary muscle that ruptured from a heart attack. So if you ever wonder what it looks like, this is a mitral valve. It looks like a parachute. This is basically would have gone down a little bit and attached to the left ventricular wall, but this thing had a heart attack in that area and it just necrosed and broke free. So they had a flailed valve with this big chunk of junk flipping around. We're like, oh my gosh, what is that? It looks like they have endocarditis. And sure enough, it's just a piece of the papillary muscle. So very, very unique things that you were into. You're like, oh my gosh, never expect to see that. But up at the top of this picture, you can see all the lines and tubes and different things going in there. There's just a ton of stuff in that small spot. And you can see the size of these DeBakey's in there holding this. You know, it's a pretty small valve. It's only about 30 or so millimeters at the biggest, usually a little smaller than that. So it's not a huge valve, it's about the size of your thumb, maybe a little bit larger. But if it's really big, doesn't work really well, or it has backflow or is all stiff, it's going to get replaced. Mitral valve replacement, like that last picture I showed you, looks about the same, but all these strings are in there to kind of hold and get retraction and expose so you can actually see what you're doing. This is something that just kind of takes a little practice. I think the hardest thing about these surgeries is you have all these different colored strings, but at least they change the colors between them so you can kind of keep them, you know, keep track of which one's which and count them. Your job as a first assistant for these valve surgeries is to kind of hold all these strings and not let them get all tangled up. It is just a pain in the neck. But that said, it's kind of a fun surgery to do as well. Sometimes you don't have to take the valve out, you can just repair it. And if you have a leaky mitral valve, that's what that looks like. What we'll do is we'll do this little ring on the outside. This ring is called a plication. I'm sorry, not plication. This is called an annuloplasty, excuse me. An annuloplasty is sometimes a fully circumferential or like a C-shaped ring, and that ring stiffens the circumference around the valve just to kind of pull it into where it should be touching properly. So if you think about my hands here, the valve is opening and closing, and there's a zone of coaptation where it should be touching together. But if you have a really dilated heart, what ends up happening is those areas still work, the valves still work, but they're being pulled apart, so they never touch. And because they're not touching, the blood is going to backflow both directions and cause more serious regurgitation, and the patient's going to have more symptoms, especially if they're hypervolemic in a CHF state. So people with mitral valve disease where they're not working very well from regurgitation, you have to watch their fluid status really well because it basically exacerbates the problem if they're pulled apart. A lot of patients, they'll have a heart attack and then they'll have mitral valve regurgitation because the heart walls die after that heart attack, and then they kind of relax a little bit, and then the valves don't close properly. So it all kind of plays together. So obviously, if we don't have to replace it, it's nice just to fix it, and then the patient can go on having their own natural valve. But any kind of prosthetic you put in here, if it's plastic, they're going to have to take some kind of bacterial endocarditis prophylaxis, take some antibiotics before dental procedures or surgeries and all of that too. So it's not a huge deal, but the valves, the mechanical valves are going to require anticoagulation. There's some cool valves out now that don't require as high of an anticoagulation number for INR. The Onyx valve's kind of cool. You can get an INR of about 1.8 to 2.5 instead of being like 2 to 3 or 2.5 to 3.5, depending on which location. So it's a little bit easier for your bleeding risks, but you still have to give a couple months at a higher level to let them kind of get, you know, broken in a little bit. But a lot of cool technology coming out of where this is going. Pretty rarely tricuspid valves get replaced. On the right side here, the tricuspid's over here. I mean, you could probably just take some of this tricuspid out and not put a valve back in there, and they would survive. It's not that big of a deal. But that said, the most common reason to have a tricuspid valve go bad is because of drug use, honestly, or endocarditis for some odd reason. But usually it's going to be a venous drug abuser, and then the drugs and the bacteria made their way in there and chewed up your tricuspid valve. And that's something that if they're an active drug user, you're not going to say, well, let's just put a new valve in there because, hey, what's going to happen to that valve? It's going to get infected too. So why put them through all of that and give them some antibiotics and get them through it and then try to stop the drug habit. And if they do stop the drug habit, maybe we'll fix it. But if they don't, we're actually putting them at higher risk because they are they're walking around with a bad tricuspid, but they could have much worse symptoms. So a really bad right ventricle is actually a really, really, really bad surgery. It seems like the left ventricle is a bigger deal, but if you have a bad dilated right ventricle, your mortality is much higher. So we don't just jump in and fix a tricuspid just because we can, unless we're in there for something else. And that's really what the guidelines show. So again, it's kind of one of those easy slam dunk thing. It's right there, but it's not something we fix all the time. The maze procedure, this is kind of a cool thing to do. Takes a little bit of time, but doing a true maze procedure is one of the best ways to stop AFib. About 80% of the time, it'll stop people that are in persistent AFib. If you imagine where the veins come back from the lungs with good blood and they plug into the atrium on the left side, that connection is two different types of actual fibers as far as the muscles themselves go. And in the embryology of when you were developed in uterus, those are the things that were that connection point between the atrium and the pipes. That junction is one of the different types of blood vessels that is the most common spot to get AFib. So they'll do cryo balloons in that spot and make a little ring around it where those vessels come in, or we can just mechanically freeze it and fry it, and then it's still kind of there. It's just like scar tissue and a ring around it, and that reduces that AFib considerably. But it may work too well and need a pacemaker. Plication is pretty rare to do this, but if you have someone who has a really nasty MI and the apex of their heart is real gross, boggy, it looks like it's not really going to last very well, or you're worried about having an aneurysm, they may just go straight to transplant, or this is something where you can more or less shorten this and wrap it, and then it'll protect it and make the heart work a little better again. So very rare to do this, but there's some places you'll do this kind of at a tertiary university level center, and it does make a difference. More than not, you'll see a lot of patients nowadays have left atrial appendage ligation all the time. Just because it's there, we'll put a little barrette-like thing across it called an AtriClip, just because that's the one spot. If somewhere down the line you get AFib, or if you have AFib, for sure you're going to get one. But this little outpouching here is the most common spot. It's kind of like if you go in a creek and there's that little side pool of standing water, that's where the mosquitoes grow. That's the same exact thing. This little spot is where AFib starts because the flow is not exactly ejecting properly when you're in AFib. So that's where we clip that, and it reduces the risk like up to 90%. Even if you're not anticoagulated, you're very low risk of getting a thrombus associated to AFib. So pretty cool to do that. If you're already in there, you might as well. Some lung surgeries, we may take a wedge resection. We're like, I'm not sure what that is, but let's take a sample and see if it's a known adenocarcinoma, squamous, or some other lung cancer. We're going to take the whole lobe. I mean, honestly, there's no good reason, unless your lung is just so poor functioning that we're like, well, we have to keep some of it, so let's just take what we have to take. But that said, it's more common to do a full lobectomy, and then around the trachea and then the main stem bronchus here, there's all kinds of lymph nodes in there, and that's what we take out so that we can get accurate tumor staging and say, hey, did this make it from being out here in the lung? Did it actually work its way to the next step, which is typically going to be these lymph nodes? And if that's not, by taking that lobe out, you're stage 1 and cured, unless it's a really big tumor and call it stage 2. But if it made it into those lymph nodes, it's a stage 3, or if it made it really far across the body of some other organ with a MET, it would be a stage 4. So a lot of this is just going to be for accurate staging as well as removing the big tumor. So this happens in a couple hours, pretty quick surgery. You can do robotic stuff if you want. It takes a little longer if you're just learning on it, but that said, it's a little bit faster recovery. Robots are fun. They're boring to assist though. Empyema, like I said, you may have the lung that's all socked in there and you have this big rind of garbage around there. It's really not fun to try to put a drain in this and hope it works, because it usually doesn't. If you take them to the OR, the sooner the better, because you can peel this rind that forms on the outside of this, and that rind means that the lung really can't expand all the way out. So if you want them to have that potential space around there where the pneumothorax or fluid could build, you want to get that lung all the way to the rib cage. So one of the things we'll do is we'll just take them and drain that fluid out, just irrigate the heck out of it, and then we'll take and peel off that pleura, and hopefully that takes care of it. So kind of a yucky procedure, but usually there's people like, I've had pneumonia for a couple months and it won't go away. And then they get an x-ray and it looks all nasty. And it's like, yeah, that's not going anywhere. They'll drain it and it basically comes out looking like brown pus. And you go, yep, we're going to be doing a decortication. So not every day, but it happens once in a while. This is kind of fun. This is called aortic root dilatation here. This is a big ascending aortic aneurysm here, all bulged out. So what we do is we would cut this out and put a new graft in here. If it's all the way down to the valve here, this is where the aortic valve is. Right next to the aortic valve is where your left and the right coronaries come in. So in that case, if we cut that all out, we have to re-implant the coronaries. So we're plugging in the left and the right coronaries into this Dacron tube, And it tends to work pretty well, but at the same time, it's kind of creepy that you're cutting their coronaries while you're doing that. It's like, yikes. So this is one of those things that typically, if we can avoid it, we always try to cut above this and leave this alone, but you can't always do that. It kind of just is what it is. If it's down in the root, you have to do the whole thing. So that's a pretty common thing to have happen. Sometimes people that have aneurysms in the ascending aorta here also have a bicuspid aortic valve, where they just have 2 leaflets instead of 3. It's a congenital abnormality, so kind of interesting. And then kind of worst case, but very infrequently you'll have a wound that falls apart. One of the more common reasons to have a wound that's kind of fallen apart here is because one side you have the internal mammary artery here that was feeding the chest wall, and a lot of surgeons will take both the left and the right internal mammary arteries here. If you take both of those, you're relying on the intercostal artery supply on the sides coming around to the sternum. And if you don't have really good terminal blood flow, you may not have really good healing here. So, you don't have a lot of anything under the skin and the fat there. It goes right down to the sternum. So when this happens, you have to do what's called an advancement flap. And we would basically go back in there, try to get it as clean as possible. But then the pec muscles, which go off to the sides, what we do is we would kind of undermine those and extend them back over both sides. And then you'd have a good bloody thing at the bottom of your incision to heal it. Or we could even take some omental fat through the belly and pull it up here and do an omental flap. The whole point is you have to build a wound on a good base of healing. And a lot of times plastic surgery gets involved in these, and it's really pretty incredible when it's all said and done how the healing looks. So you can start up here with this big dehiscence that looks awful, and then it starts healing in, and by the time you're all done, it really does look like nothing was there. And this was an omental flap pulling up through the belly up into the chest to heal it. So pretty cool. You can see this big round ball here. That's all muscle that was pulled up and omentum. So pretty neat. So not every day, but it's a big surgery. So those are some of the surgeries that I see, in my life. A day in the life of surgery, depending on what the case is, would probably start about 7 a.m. for the first case. So your patient's to the hospital about 5 or 6 o'clock in the morning, getting ready and pre-op. You may check them in and kind of go through anything if there's an H&P to update, if there's any labs or testing you're waiting on. But usually you've got them all ready well before this. You meet the family, talk to them, you've signed consent, you're ready to rock and roll. They wheel into the OR where I work at 7 a.m. and then they're off to sleep and ready to go about 7:30 with their lines and everything. Some places will do the lines, like a central line, art lines and all that before in like the anesthesia bay, so it doesn't slow you down too much. But typically it's a 3 to 5 hour surgery, sometimes longer depending on what you're having done. And then afterwards, you're going to be one of the first people to start the case as a first assist, and you're going to be the last people to walk out of the room. The surgeon will typically break scrub, and then you'll finish after you get the wires all put together, and then we'll do all the layer closure over the incision. So very important to make sure you understand good layer closure and wound approximation. And then you'll take the patient directly to the ICU, and you'll basically wait for a couple minutes until they're nice and stable. And then at that point, since I'm the NP for the group, I could write orders and get everything ready to go and follow along for half an hour or so, make sure everything's stable. Or if we got another case, we're turn and burn and go do another case. It just kind of is what it is. And that patient from that first case, typically mid-afternoon, they're going to wake up, the breathing tube's still in, kind of slowly waking up from anesthesia. And then by dinner time, we'll have the breathing tube out and they're sitting up and they're probably a little uncomfortable, a little bit groggy. The pain's usually worse the next day, but they'll be up in the chair and moving around a little bit more by then. And usually, like I said, 4 or 5 days, usually they're going home. So post-op day one, here's just a patient from probably the 1980s that I found that, he's up in the chair. It's awesome. He's doing what he's doing. He's, they're assessing his leg. You got an ACE wrap on the site. They had the vein harvest. They're just kind of watching. How's it going? He's pretty far along. He's, doesn't have his lines and tubes anymore. Down here at the bottom, this is what you typically see your patient looking like when they come back. Lots of pumps, lots of tubing, ventilators, there's a lot going on. But you may be in charge as the NP, like I am. You may be managing their vent weans and managing their drips and pressors and all that. Or maybe there's an intensivist in the ICU that does that for you, and your job is more in the OR. There's lots of different ways this can look, and it's a lot of fun. Pulling out lines, pulling out wires, starting walking, starting moving, and eventually you're going to transfer them up to the next floor that's not nice to you typically until they're ready to go home. And then the post-op day number 2-ish, 2 or 3, whenever they're off all their drips and looking good, until whenever, then they're going to stay in the hospital, keep walking, keep moving, get ready to rock and roll, make sure your bowels work, make sure the lines are out, make sure the drips are out, eating food right, doing the stairs, getting showered. Once you're all ready to rock and roll, Most people will go home after this, about 85% of the time. And then some people still need to go to subacute rehabs because they don't have family at home to help them, or maybe they had a stroke or some complication that was unforeseen, and they'll go to an acute care rehab center or potentially an LTAC. But most of the time people go home and I see them the next week after in the clinic and they're feeling pretty good. So that's the typical process. And, my job is going to be both getting them into the OR with all the pre-op workup, doing the cases, and then afterwards managing them in the hospital until they're ready to go home. And then I see them in the clinic also. So I really do get a cool lifespan of the patient's care relative to the surgery. And we see people, we just follow them for their aneurysms. We'll see them in 6 months or a year or whatever and say, hey, nothing's changed. So we get these really long-term relationships going, and it's pretty fun. So I really enjoy it. So real quick, preparing for the CV surgery first assist role, what are the skills that I needed? Well, the obvious one for me was endoscopic vein harvesting, fine suture management, learning how to work with like 6-0s, 7-0s, sometimes 8-0s for doing all of your approximation. One thing that's not on here that I would certainly add is working with surgical loops, which are surgical telescopes that are fitted just for you. That's kind of a weird skill you have to learn. But again, no big deal. You just have to learn how to work with it. Following suture, which is kind of getting the junk out of whoever's working's face so they don't have a big bundle of monofilaments in their way. Keeping tension on lines when you're doing good approximations. You cut in the aorta to get to the aortic valve, and now you got to stitch it back up. Well, you got to hold tension on that so you close it and keep it nice and taut. Suction, irrigation, all the obvious things. Big part of my job is multiple layer closure. So doing fascia and sub-Q and dermis, port sites, EVH sites, all of that. Central lines, chest tubes, art lines, Foleys. That's the big things that I had to learn how to do for my job. And again, I started in this as a family nurse practitioner. So none of this was taught in my curriculum, and there's no operative medicine taught in any curriculum. So if it is, it's only as an add-on to the core curriculum. It's not something that's actually part of the main curriculum of either an acute care or a family nurse practitioner. So all I have to say, if you want to learn operative stuff, you're going to have to get follow-on training to be in the operative setting like an RNFA. And again, that brings me to the NIFA course. So when I did it, it was a 6-day course. Now it's a 5-day course. Still has the same content. It's just been kind of retooled for the timeline. And for me, that was a big deal going through that. I had no experience. Again, I was, ICU nurse and critical care, trauma, that kind of stuff is great, but I had never thrown a stitch when I went into the OR. So it was pretty much starting from scratch. I know I was probably a liability in there. I didn't really have any idea what to do or not to do. So I just kind of tried to not touch things for a while. And when I went through the NIFA workshop, Dean Parsons, who's the director of that, he made such a lasting impact on me, honestly. He made me learn in ways that were very memorable with fun analogies. You go into it, you're thinking like, oh my gosh, I'm gonna be so stressed out. And halfway through, you're like, I'm waiting for the shoe to drop. This is not, this isn't like a terrible experience. This is freaking awesome. And then you finally realize like, this is actually, the whole thing is awesome. This is not going to be like a scary, awful thing. This is a fun environment. You're going to take these skills. You're going to learn them in a controlled environment. You have the ability to ask as many stupid questions as you want. And I needed that. So it was really, really helpful. I learned how to do vein harvesting there, doing graft suturing. There's a AAA day, multiple layer suturing. That's like, if you've gone through that program, we do tons and tons of multiple layer suturing. And that really came in handy for me. Tension management, some of the trauma stitches I've used that they taught me that are very valuable. I follow suture all the time. And there's a fun joke that Dean likes to talk about. But that said, following suture is one of those things that there's an art to it. And I always remember how he taught me to do it. That 5 days of intensive hands-on training is nothing like, I learned here, I learned there. I mean, to really give you that intensive hands-on, it just really gets your hands working. It's all hand tying. It's all those things that really, unless someone's showing you and you're putting it to the procedures, you're going to forget it. And then after you do that, it's a jump start into the OR so that you're ready to start your clinicals for the 140 hours and really be prepared. And people told me before and after that workshop, they said, what did they feed you? What's in that water? I came back and I just felt like, I was like, I got this. I get it. It makes sense now. And I understand that I still don't know half of the stuff about what the instruments are called unique to this. I'll learn that. I started doing some counts with the scrubs and it made a big difference. And with time, they started to see me as part of the team and not a liability. The vein got faster taking it out for the harvest and all of that, and it got better quality. It's just one of those things that, you know, you just have to do the reps to get it, but it really set me on the right trajectory. So for me, that's one of the main reasons that I'm such an advocate for NIFA, because if I didn't go through NIFA, I certainly would not be where I am today in my skill set or in my career. And I can tell you right now, I get calls probably 2 or 3 times a week from people that are recruiters saying, hey, we need someone to come do locums for vein harvesting here and there. And I can tell them, sure, I could do it, but I have something else going on or whatever, or sure, I can go do it. And however that looks like, it's not like, well, I don't know how to do that, I'm probably gonna, no, I'm comfortable doing it. And NIFA really set down that environment for me to be successful. So, and if anyone asks everywhere I go, I say, well, who did your training to get credential? And say, I did NIFA. And they go, oh, got it, no big deal. So there is just something about that that I think is a valuable resource when you don't have to fight that. It's like, oh, where'd you go? I went to Harvard. Oh, cool, we know what Harvard is. Oh, NIFA? Oh yeah, we know what NIFA is. You're good. That was why I chose it. Oh, and one of the fun point, and the skill set I learned in NIFA was very specific to the OR, and it got my mind going as I was doing a lot of my work on my DNP. But all the other things that had nothing to do specifically to the operating room, central lines, chest tubes, art lines, intubation, ultrasounds, thoracentesis, lumbar punctures, you know, all that kind of stuff I have to do in my job, but I didn't really know how to do that. So we offer courses in all of that now. And we work very closely with NIFA because we basically are hand in hand to make sure that you have the training you need. And this is our Skills on Point mobile. I should nickname it something cool, but I have no name for it. But the idea here is you can kind of see some of the fun stuff we do. We have custom made instruments that are super high quality, so you can train on gear that actually feels like what you're in the OR with. We use a lot of different ultrasound guided training gear. This is actually a surgeon from the Dominican, and she's learning how to do vein harvesting, and she's always done open harvest. So it was pretty cool to have a cardiothoracic surgeon. It's like, wow, you're way above my pay grade. She's like, but I have no idea how to do vein harvesting. It's like, we'll teach you. It's all good. And some really cool relationships that come out of it. So actually down here on the right, this is actually at a NIFA course in Vegas last year. We were doing some ultrasound guided central lines and stuff. So super fun. All that to say, my goal as well as NIFA's goal is to make sure you have the training you need. And certainly, if nothing else, know that you have resources of people that want to make sure you're successful. And if you have questions about the programs, if you have questions about, you know, the different things that I do, I'm more than happy to answer any questions you have. This is my info right here. I'll leave this up for you. john.russell@aprn.com. Great way to get a hold of me. Skillsonpoint.com is our website. If you have any need for skills or whatnot, just because you guys are spending time with me, this discount code SWEET will get you 30% off stuff, which is kind of fun. All kinds of fun courses on there. That's my cell phone number. I want you to know that if you have any questions at any point in time, I want you to reach out, because I don't necessarily know that I'll have the answer, but I'm certainly going to try my absolute best to make sure that we can get you the answer that makes sense for how you can apply it. Every state's unique when it comes to APRN rules in the OR. Every hospital is unique with that too. So there's no one answer fits all typically, but do realize that you are very wise to consider an APRN RNFA if you have the opportunity to do that. I mean, I got to tell you, it's the best thing you can do, because once you have that, it's there forever. You don't lose it. It's like, you know, one of those things that people beg for. They would kill for the opportunity to be in the OR as an RNFA. And if you're the person that has that opportunity and says, I don't really want to do this, realize that that's a pretty big, awesome opportunity to pass up on. And if it's just because you're like, I don't know if I have the training or the cost or the time, or trust me, it's worth it. It will pay back in dividends.